It's crucial to understand that, in fact, if you really think about it, what is commonly perceived as fertility treatment and IVF is actually the last step in a long journey. The World Health Organization estimates that around 17% of all couples in the reproductive age group need help to get pregnant. That is a huge number.
When we say IVF, actually it's a very generic term.
Why is it called in vitro fertilization? When something happens in the body, it's in vivo. And when something happens outside the body, it's in vitro. Technically speaking, whenever you do an embryo transfer, for that moment she's pregnant. Alright, the trick is to remain pregnant. Okay? The couple should have tried at least for a year, which is unprotected intercourse, before you can say that they are unable to conceive on their own and need some kind of assistance. Age is actually the most important factor in outcome in fertility treatment. It is our responsibility as healthcare providers for women to not make any decisions for the woman of when she should conceive. It's our responsibility that we have to enable her to plan her family when she would like to have a child. We are very clear about that.
Hi, I'm Drashti. I know there are a million podcasts out there talking about fertility, but this one's a little different. This is about a science that is deeply personal, often misunderstood, which is the science of IVF. Now, who better to understand this from India's two leading gynecologists and co-founders of Pluro, Dr. Jaydeep Tank and Dr. Parikshit Tank. So we understand what truly it means to start a family in today's day and age, given our lifestyle, given the circumstances that we live in. So let's dive in and direct to the doctors. So Dr. Tanks, IVF as a term is often misunderstood. So if you maybe had to explain somebody over a cup of coffee or in the simplest way possible, how would you do that? Dr. Parikshit.
Right. So when we say IVF, actually it's a very generic term. The correct scientific terminology is ART, that is assisted reproductive techniques. IVF is one of those assisted reproductive techniques. To put it very simply, the concept is that you make or generate more eggs in a woman's ovaries, get them out into the lab, have the husband or the partner give the semen sample, select good sperms from there, join these together, boom, it's a pregnancy. You grow it in the lab and then put it back into the woman's uterus. So that's the nutshell about what IVF is all about.
Just to add, in terms of terminology, why is it called in vitro fertilization? When something happens in the body, it's in vivo. And when something happens outside the body, it's in vitro. Over here, the basic process which happens outside the body is fertilization. Fertilization is the union of the sperm and the egg. And this happens in two ways. One, where the sperm is just placed around the egg. And there's another one, which actually is one of the most magnificent breakthroughs in medicine, which is called intracytoplasmic sperm injection, otherwise popularly called ICSI, where we now have the technical ability to inject one sperm directly into one egg. So this process where the sperm and the egg come together is called fertilization. It could occur inside the body, in which case it is in vivo, and it could occur outside the body, in which case it is in vitro. Vitreous, the word is derived from vitreous for glass, and that's why it's called in vitro. So just to sort of, outline why it's called IVF. And IVF, as Parikshit rightly said, is a very broad term, engaging a host of technologies, which we can talk about as we go along.
Thank you, doctor. So we've often heard about the words IVF. We've also heard IUI, ICSI. For us, it's like an alphabet soup. But if you could probably help us understand the meaning of each and who should be going forward for these treatments.
Sure. It's crucial to understand that, in fact, if you really think about it, what is commonly perceived as fertility treatment and IVF is actually the last step in a long journey. The World Health Organization estimates that around 17% of all couples in the reproductive age group need help to get pregnant. That is a huge number.
Absolutely.
Unfortunately, sometimes I feel that fertility is not perceived as a public health problem. But how can it not be a public health problem if it affects 17% of all couples in the reproductive age group? You're looking at literally millions of people in India and around the world who have this issue. It is therefore very much a public health problem. And there is a cascade of events which needs to be followed when you talk about the treatment of fertility. It actually starts with the fact that the couple needs an adequate time to conceive on their own. For example, the World Health Organization again recommends that the couple should have tried at least for a year, which is unprotected intercourse, for at least a year before you can say that they are unable to conceive on their own and need some kind of assistance. The first step towards giving this assistance is in fact investigating the couple. So at its very basic, if you look at the building blocks of pregnancy, you need a sperm, you need an egg, and you need the ecosystem in the pelvis of the woman to be appropriate, which would, be the uterus, the tubes, the ovaries. So at its very basic, these are the building blocks, and therefore the investigations that we do are configured to look at whether these building blocks are appropriate or not. Now, once you have all these building blocks in place, the first step actually is to do a very simple treatment called oral ovulation induction. With oral ovulation induction, the logic is that you give the woman a drug, either clomiphene citrate or letrozole, and try and encourage the ovary to produce a good quality and quantity of eggs. And the quantity of the eggs that are produced in every treatment is quite different. So there's a range. For an intrauterine insemination or oral ovulation induction, 1 to 3 eggs would be considered to be appropriate. But if you're looking at an IVF, then probably anywhere between 8 to 12 would be considered to be appropriate. The very simple way to explain oral ovulation induction is that you give certain drugs, encourage the ovary to produce more and better kind of eggs, and on the appropriate day, which you gauge by doing an ultrasound, you give a trigger. This trigger is typically a molecule known as HCG or a GnRH agonist. Once the trigger is given, you ask the couple to keep relations. It's a very simple treatment, very basic treatment. And correspondingly, the pregnancy rate that you can obtain is anywhere in the range of 8 to 10% with this very, very simple treatment. Again, to contextualize it, the natural fecundity and fertility of a couple where everything is normal is around 4 to 5%. And I always tell my patients this, that, couples just keeping relations once and conceiving typically happens only in Hindi movies. It's not something which really happens very often. There are occasions when it happens, but it's not really very common. There is a certain element of time which is taken for the couple to conceive. We typically try oral ovulation induction for around 3 to 6 months, depending on what we call the fertility potential, which takes into account the age, the ovarian reserve, and a host of other factors. And if that doesn't work, then we move on to step 2, which is intrauterine insemination. And Parikshit, would you like to talk about IUI?
So when we talk about IUI as a treatment, you're looking at two important components. One is generating the eggs in a little more number than what would naturally happen. So typically in any cycle that a woman has, she will usually just produce one egg. When we are doing stimulation for an IUI treatment, the idea is to get that number up from 1 to maybe 2 or 3, but not beyond that though. Obviously, because there are more eggs out there, the hit rate will improve. So how do we achieve this egg making? We do it with a combination of tablets, injections, or sometimes just injections, which are taken over a course of about 10 to 12 days. That's how long it will take to generate the eggs to an appropriate size. That's where we get the mature eggs. And then we give the trigger. The trigger essentially gets the eggs to ovulate. That means leave the ovaries and hopefully go into the fallopian tubes. This is what we call phase 1. That's the ovarian stimulation part. And the other part is IUI per se, the procedure. The full form is intrauterine insemination. So what does this involve? The male, the husband, gives a semen sample. The semen sample contains so many things besides sperm actually, which are not necessarily useful for fertilization. So in the lab, the first thing that is done is select the best sperms and remove the products or the contents which are not useful and which might actually create some problems for the woman if they were just placed directly into her uterus. So what we get from that raw semen sample is a prepared or a washed semen sample, and this is placed into the woman's uterus. The purpose of doing this is to shorten the journey that the sperm has to take to go and meet the egg in the fallopian tube. So both these things put together is what comprises a good IUI cycle.
So, doctors, we've covered OUI and IUI. But just again, these alphabet soups that we have, what is an ICSI and what is an IVF? And what I've understood so far is that couples who do not conceive with an OUI and an IUI move forward with an ICSI or an IVF, which I would want to understand from you.
So, I mean, if we look at what is the difference between these two, it's essentially the technique which is used in the lab to fertilize the egg with the sperm. So that's the essential difference. For the couple, actually, they wouldn't realize whether it's an IVF cycle or an ICSI cycle. For them, it's all the same. They'll have the same steps. The woman will take injections. She'll be monitored by ultrasound. A procedure will be done where the eggs are collected from her ovaries and the man gives a semen sample. Now, what we do in the lab is the difference between IVF and ICSI. IVF is in vitro fertilization and ICSI is intracytoplasmic sperm injection. So in IVF, essentially, we layer the egg with a large number of sperms, and one of these sperms will then go on and fertilize the egg and an embryo or a pregnancy is created. Whereas in an ICSI, one egg is injected. That means you select one sperm and you push that sperm into the egg, and then that's how the pregnancy gets created. Now both techniques have their places. So let's say, for example, if you're looking at a couple where a man has a very, very low sperm count and you've retrieved just a few sperms from the testes, you would obviously need an ICSI procedure because that's how you're going to get these two to unite. Whereas for other couples, let's say for example, it's a couple where there is a tubal block on both the sides. This couple can have an IVF procedure. So essentially the endpoint is the same, creating embryos, and that's the difference between these two techniques. Does either of them really affect the success rate? No, not really. If all things were equal, they would both result in the same number of pregnancies that couples would have. So it's not that one is superior or one is better than the other. It's just two different techniques to achieve the goal of creating embryos.
All right.
So if you look at the steps of how you achieve the goal, for a patient, it would mean that she first, as Parikshit said, has to take injections. Once the eggs are ready, and you determine that by doing a sonography, there is a trigger that is given. Now the trigger doesn't produce an explosive event, all right, when the egg comes out, It's a slow release of the egg by dissolution of the membrane. But in the case of IVF, we actually use an ultrasound. So the woman's taken into the theater. She's given general anesthesia. It's a painless procedure. We then do an ultrasound vaginally or from below. And then we use a special needle through which we aspirate the eggs that are produced in that month. It's a myth that if you aspirate the eggs, you're reducing the total number of eggs available to her for her lifetime. You're only removing the eggs which have grown in that month. And again, just to contextualize, a woman is literally born with millions of eggs. And over a period of time, as she ages, the number of eggs reduces by a process known as atrophy or atopy. So even if you remove, for example, 20 eggs in a given cycle, it doesn't mean that she's going to be prone to early menopause or anything of that sort. So she undergoes the egg pickup. Then, as Parikshit said, there is the fertilization, which is either an IVF or an ICSI. Then there's an embryo transfer, where we select one, at most two embryos, and we put them back into the uterus. And then, and this is the sort of challenging part, because once the embryo is in the uterus, we really don't understand the exact science or the mechanism by which that embryo burrows into the wall of the uterus and she gets pregnant. Technically speaking, whenever you do an embryo transfer, for that moment she's pregnant. All right, the trick is to remain pregnant.
Absolutely.
Okay. What leads to that is not known. That's really the limiting step in IVF currently. We are very good at getting eggs. We are very good at fertilization. We are very good at actually doing the embryo transfer. But our ability to influence events after the embryos are put into the uterus is quite limited. People talk a lot about empiric drugs, reducing stress, doing yoga, etc. But all this has a very, very limited effect on the pregnancy. So once you've done the embryo transfer, in effect, a dialogue has to occur between the embryo that has been put in and the lining of the uterus. And if this dialogue is successful and each one negotiates well with each other, she finally gets pregnant. And honestly speaking, for a lot of women, the most difficult part of the treatment is not undergoing the treatment. It is that period from the embryo transfer to when we know the result, which is around 14 days down the line. That waiting is really a very difficult period, and women really need to sort of, take care of themselves. So Parikshit and me, we encourage women to go to work. There used to be this concept that once you have an embryo transfer, you take bed rest, you don't stress, and so on and so forth. We now know that it doesn't really affect the outcome. In fact, it is better for someone to remain occupied and keep on working rather than just sitting at home and thinking about the outcome 24/7 for the next 14 days. Right? That really is a very difficult period, which unfortunately we still have not understood fully and have almost no influence over. There is also the fact, Dashti and Parikshit will agree with me, that as of now, IVF has become incredibly safe. Whenever you talk to anyone about a medical treatment, one always gets asked, what are the side effects?
Right.
And honestly speaking, I think there are two major problems in IVF, both of which I must say have been overcome. Let me preface by saying that. One is what we call ovarian hyperstimulation, and the other is called multiple pregnancy. Multiple pregnancy means she has more than one embryo which gets implanted, which results in twins, triplets, etc. We found the answer to multiple pregnancy and tried to arrive at a solution for it simply by transferring fewer embryos. It stands to reason that if you transfer only one embryo, your chances of a multiple pregnancy occurring are going to be correspondingly low because you just transferred one. There is something where that embryo can split and become twins, but that's quite rare. For ovarian hyperstimulation, and I'm happy to share that we were actually one of the first people in India to start following this protocol. There is a new protocol called a agonist trigger in an antagonist cycle. And that has completely completely obviated the risk of a woman having hyperstimulation. Again, a bit of a background. Hyperstimulation means there is a production and women have different sensitivities to the injections. You may give the same dose to a woman of the same age and get vastly different responses. So sometimes there are women who produce more than 15 eggs. And this is obviously a problem, which is the ovary, which is supposed to hold one egg, between the two of them are now holding 15. So like any other organ in the body, this causes a swelling of the organ. And like any other organ in the body, when swelling takes place, fluid production from that swelling occurs. And this can really create a big problem. The classic incidence of hyperstimulation was supposed to be around 5%. But with the new protocol that is followed, it's become so safe that we have not seen, I think, Parikshit, hyperstimulation since 2012. So it's really changed the way we do IVF. We are much more confident and we are much more sure that we'll be able to achieve IVF results without significantly compromising or in any way compromising the safety for a woman.
So I think a number of couples, when they come to the clinic, they ask, Doctor, why have you written multiple pregnancy under the heading of side effects? You know, that's a common question. They would be like, great, I'll get 2 for the price of 1. But actually carrying a twin pregnancy has its own set of risks. The likelihood that a woman will get hypertension, diabetes, a low blood count, anemia, and most importantly, go into labor early. They are all much more with a twin pregnancy than a singleton. And that's why we are moving increasingly towards transferring just one well-selected day 5 embryo, or technically what's called a blastocyst. At the most, in some women, we'll go for 2, but that's about it. In the beginning of our careers, it was very common and it was the general practice to transfer 3 or maybe even 4 embryos. I'm talking about 25 years ago, please. So from those days, I think a significant leap in our understanding in the selection of which one is going to really give us a result, and reducing that number so that the pregnancy also is a healthy one. It's as close to a pregnancy which has been conceived without doing IVF. That's the whole goal.
Understood. So what we understand is that obviously where the patient is in her journey, the age, the other factors are surrounding it. But if you had to probably define, say, a success rate for all of these procedures, given all of the circumstances that the patient is in, how would you want to do that? Because we understand that IVF might not be just one single process, but it might be a repetition of cycles, which is just not there economically, but also from a mental health standpoint. Where does a woman stand after multiple cycles?
I think, Rashid, success rates in IVF and fertility in general is something which is not really very well understood. There are various levels of the treatment and the success rate for each is different. And therefore, it's very difficult to say that this should be the global benchmark of success. For example, you referred to age. Age is actually the most important factor in outcome in fertility treatment. Obviously, age is irreversible. If you are 40 or 40, it doesn't mean you can't get pregnant, but it does become that much more difficult to get pregnant. Now, having said that, we clearly believe that it is our responsibility as healthcare providers for women to not make any decisions for the woman of when she should conceive. It's our responsibility that we have to enable her to plan her family when she would like to have a child. We are very clear about that. But having said that, there is also no doubt that age plays a significant role in success. So if someone says, for example, that my success rate is 80%, it would be appropriate to think about what that means. Globally, the benchmark of success rate is in 2 parts. There is what is known as a clinical pregnancy rate, which means a pregnancy which is seen on sonography after treatment. There is something which is called a beta HCG positive pregnancy rate. And then lastly, there is the take-home baby rate. Take-home baby rate means the couple actually takes a baby home. And all three are vastly different. There is a waterfall or a cascade of events which causes women to actually lose pregnancies at every point. So for example, your beta HCG positives will be the highest rate. Your clinical pregnancy rate will be one step below that, and your take-home baby rate will be one step below that. And each of this is different depending on why the IVF was done, at what age it was done, and finally what was the response of the woman and the egg and the embryo quality. So what I'm really trying to say is that there's no easy answer to success rate. It has to be contextualized for every patient. If you look at data from the Human Fertilization and Embryology Authority in the UK, the ESHRE Consortium, which is the European Society of Human Reproduction Consortium, and the SART, that's the Society of Assisted Reproduction Technologies from the US, and they report data quite well. The global accepted pregnancy rate, and again there is a difference here between pregnancy rate per cycle started, pregnancy rate per embryo transfer done, and pregnancy rate per embryo that is transferred. So again, what I'm trying to say is that when someone says my success rate's 80%, it can't be looked upon as a global benchmark. It doesn't mean that 100 people who go there, out of that 80 get pregnant. It certainly does not mean that. It's much, much more complex than that. But what is globally acceptable from all these kind of registries, etc., is that if you have a success rate between 35 and 40% of clinical pregnancy rate, then you are all right. Anything more is of course good. For example, even in our own instance, when we look at the cycles where we use donor oocytes, our success rates regularly hit 65%. But if you look at the global success rate, I mean, you consider women at all ages, all conditions, all kind of responses. You have an IVF center which does anywhere between 35 and 40 or 45%, then that's a well-functioning IVF center. So again, to answer the question, there's really no easy answer. There are several success rate calculators which are available on the App Store. Many scientists have tried to develop algorithms. The problem is that there are simply too many variables to take into account to say that, all right, this is going to be your success rate.
I think when couples come to a clinic, they want to have some kind of a realistic number, which they can look at as achievable by a particular clinic. And our job as clinicians is to give them the correct information in a way they can understand that. So individualization is very important when we are talking to couples, when we are consulting with them as to the line of treatment that they are going to follow. And that's going to influence the type of treatment, and in some situations, even whether a couple would like to go ahead with any sort of treatment given the success rates what are expected. So I think rather than putting one single number out there that, okay, this is the success rate of IVF, we need to contextualize it as to whom we are giving that number to.
And I always tell patients this, that I'm telling you 40% or I'm telling you 50% is your success rate. But what does it matter to the individual? For the individual, it matters whether the couple gets pregnant, right? Whether he or she get pregnant. Because when they achieve a pregnancy, for them it's 100%. All right? For them it's a binary, right? They are either pregnant or they're not pregnant. You cannot, for example, be slightly pregnant. All right? You can either be pregnant or you are not pregnant. And that's why I think this whole conflation, confusion about success rates needs to be addressed with much more information which patients should receive. And I hope that in Pluro going forward, we will be able to establish benchmarks which are clear, which are transparent, and which provide patients with an appropriate knowledge of both. As I've already said, the risks of IVF are really now obviated to a large extent. But in terms of success rates and benchmarks, we hope that patients who come to us will actually be able to understand consciously what the chances of them achieving a pregnancy are, absolutely in a transparent way.
Understood. So, doctors, we've understood that success rates depend at a patient level and the multiple factors that go on with that particular patient. But to say dive deep a little further, people always get confused with the hormones that the women carries. And FSH, LH, AMH, they're very fancy terms that we hear, and often we get really confused as to which one kind of aligns for us and is applicable for us, and whether we should probably get tested for it and at what age. And if you could probably throw some light on that so that we'll be more aware about it.
Right. So, checking for hormones is done through blood tests. And for a woman, the understanding is that there should be a correlation between certain hormonal levels and the number of eggs that she can produce, or what's simply called as the ovarian reserve. So, tests like FSH, LH, and AMH are all designed for that purpose. Now, when we look at the range of hormonal tests which are available, there's this group, the FSH, LH, and AMH. That's one segment which looks at ovarian reserve. But we also look at a couple of other hormones. That's the TSH, the thyroid hormone, and the prolactin, just to complete the endocrine picture or the hormonal picture. A very few women will need more specialized testing. For example, women with PCOS will need their androgens, that means the male hormone. Yeah, I mean, women also have the male hormone in them, and we need to test that on certain occasions only. So that's the entire gamut we have. Now let's go into the ones that you asked about, FSH, LH, and AMH. Now, currently speaking, probably the most commonly used test for ovarian reserve is AMH. FSH was the standard test maybe 15 years back or so, but today we are increasingly relying on AMH as the test which will give us an indication of what the egg producing capacity a woman has. AMH can be done on any day of the cycle. There's no particular day on which it needs to be done. Compared to that, FSH has to be measured only on the second or third day. That means when a woman gets her period, the day after that or the third day. Both of them will give us some indication about the number of eggs that a woman can produce. But unfortunately, there's no test for quality. It's just quantity that you can estimate from these hormone levels. You can't say that, okay, this woman has an excellent chance of producing 10 eggs if I give her injections. But how are those eggs going to be? I don't know. Conversely, you can have a young woman who has a low AMH and may produce only 3 or 4 eggs, but they may be very good quality and would result into a pregnancy. So again, I go back to the point of individualization and putting into context what these numbers stand for. Should women check their AMH levels randomly? Please no. What that does is set about a series of events which almost inevitably leads to panic, because there's no perfect number. We don't know whether at an age of 30, if a woman's AMH is 2, is that okay, and can she defer a pregnancy by 2 years or 3 years? Nobody can answer that. That's like looking into a crystal ball. I don't know where the Sensex is going to open tomorrow. I don't know where that AMH is going to take the woman in the next 2 or 3 years. At best, you can look upon it as a very rough marker, but nothing more than that.
Understood.
I also think that if you now I've been a doctor for 32 years now, And I am always, even now, astonished by how complex the human body is. And given the fact that there are so many things that can go wrong, things go wrong only in a small number of people. Just think about the complexity of hormones, for example. It's really a very complex interplay with positive and negative feedback loops built into it and so on. And if you think about it, it's just like a symphony, where one discordant note in one small instrument somewhere can really jar the sound that is produced by the whole orchestra. If you look at hormones which affect pregnancy, there is something called a hypothalamo-pituitary-ovarian axis. Each part of this produces different hormones. Each part of this has got sensitive loops built into them which regulate and promote the production of one hormone or another. So the hypothalamus produces something called GnRH. The GnRH stimulates the pituitary, and these both organs are in the brain, mind you, at the opposite end of the body in a way. The GnRH stimulates the pituitary, which is actually a small organ at the base of the brain, to produce FSH and LH. FSH and LH act on the ovary to make the ovary grow an egg and produce estrogen and progesterone. And the estrogen and progesterone ultimately have an effect on the lining of the uterus. Estrogen and progesterone not only have a effect on the lining of the uterus, they also have an effect on the mucus that is produced from the mouth of the uterus, which is the cervix. Just to give you again, a fairly astonishing example, if you think about how nature works. In the first part of the cycle, the level of estrogen is high. This causes the mucus in the cervix to be very thin and filmy. And this is to allow the sperms to ascend into the uterus easily. Once ovulation has taken place, that means the egg comes out, progesterone rises, and the ability of progesterone on the mucus is to now make the mucus thick and not allow the sperm to go across, because the function of the cervix in a way is to act as a filter for the sperm. I mean, just think about it. I mean, if you were to, for example, build something as complex as the human body in the outside world, outside the human body, I don't think humans are at a stage where we can actually do it, despite all kinds of artificial intelligence. And everything is so sensitive, but at the same time has got a lot of tolerance for things getting out of sync. So if you think about it, reproductive endocrinology is actually one of the most beautiful parts of the human body. Okay, everything depends on each other, and at the same time there is adequate tolerance built into the human body so that small changes in hormones doesn't really throw things out of whack.
So this has been such an eye-opening conversation, Dr. Jaydeep and Dr. Parikshit. This might just be another podcast, but we feel that it has left the viewers with more clarity, comfort, and maybe a sense of hope as to when they embark on their fertility journey. Thank you for tuning into the Pluro podcast. Till then, keep asking questions and see you very soon.
Thank you, Drishti.
Thank you.